So the first question was, can Gemzar cause high blood pressure? And there was a follow-up question to that. She's asking that she had radiation to the neck last summer, and so during her fourth cycle treatment with the Gemzar, and she had this red area that appeared on that tumor on the neck, and it was after 10 days of antibiotics, it went away, but she had what she goes on to say that she had her first treatment on cycle 5 with no problems, but then she couldn't have 2 treatments due to low white count. So her question is, have you seen ovarian go to the neck and not been responsive to chemo? I didn't respond to Doxil at all. I'm not a candidate for surgery. I have seen a neck specialist in oncology. He's saying it's too risky. I have battled ovarian cancer for 11 years. Quality of life is important to me. My daughter is having my first grandson in May. Trial life is not for me. Any suggestions and comments to my situation would be helpful.
Hmm. So I think I think I hear of several questions within that statement. Certainly, yes, ovarian cancer can travel to the neck. It can travel to the supraclavicular area, so the area above the clavicle. It can also travel into lymph nodes in the cervical chain within the neck. It is pretty rare, but it can certainly happen. Anything can happen. That that neck lymph node would be the only lymph node, but if it is, then and I don't know the specifics about previous treatment, but if it's not removable, and a lot of times, to do neck surgery is pretty intensive to do. Radiation therapy can be delivered to that specific lymph node in the neck, especially if it's bothering somebody. It's big or it's rubbing against something, or maybe it hurts a little bit. So yeah, I think that's very possible. The other questions were around gemcitabine. I thought I heard one question was, can gemcitabine cause hypertension? That would be very, any drug can cause any side effect, I suppose, but gemcitabine causing hypertension, if gemcitabine is combined with Avastin or bevacizumab, then the risk of hypertension or high blood pressure is much more so. There are some rare side effects of gemcitabine where gemcitabine can damage blood vessels. So I guess that could be a manifestation if that occurred, but I would think about other reasons why blood pressure may be coming out. Yeah, sometimes, hypertension or high blood pressure is 50% of the American population has high blood pressure. So it's a common chronic disease. You also mentioned that she also experienced low blood counts. That is very, very, very common with gemcitabine. So I hope I answered that question. Okay.
Yes, thank you so very much. The next question was that Sandy, she's asking, can you address the problem of having severe side effects on a drug that is most effective for your particular cancer? So, in other words, the treatment is working, but it is causing tremendous side effects. So how do you address that problem? And then also as a follow-up, what are the newest treatments on the horizon for a recurrent ovarian cancer?
Yeah. So absolutely, unfortunately, that can happen where the therapy is really working quite well, and then some side effect comes up that is, really impactful for that individual, and it can be from fatigue. It can be severe drops in blood counts that we maybe can't necessarily totally fix with Neupogen. I'm sorry, it's our hopefully you can't hear those dogs barking. I may have to move to another room. Um, and so sometimes we can't totally fix the drop in blood counts. Um, what we're seeing with other medications, such as antibody drug conjugates, are side effects such as lung toxicity, so pneumonitis, the drug Elahere or mirvetuximab can cause eye side effects. Those are reversible. Um, Neuropathy, another side effect that can be long lasting and can be a reason maybe to need to stop treatment or to lower the dose. So if somebody comes in with a side effect that is, I think, reversible, like neuropathy, we're not necessarily fully reversible, but at least we can try to make it better. Maybe I'll hold the drug for a little bit, and or reduce the dose. So I think in many circumstances, I wouldn't say in all circumstances, unfortunately, but in many circumstances, the side effects of the treatment can be mitigated. There are occasionally times when, you get a side effect that you cannot overcome. Those side effects to me would be something like, someone's kidney function changes severely, like with the drug cisplatin. If someone's getting intraperitoneal cisplatin, a bowel perforation with Avastin, really significant neuropathy, or as we're seeing with some of the antibody-drug conjugates, significant lung toxicity, pneumonitis. Those would be examples of types of side effects where I don't think that we're able to, overcome them, and we would have to, change the drug, change the strategy of the treatment. I mean, there's a lot going on in terms of different therapies. And I think that there are, the way I would think about things would be based upon, so new therapy is based upon the histology of the ovarian cancer. So high-grade serous, low-grade serous, clear cell, mucinous, endometrioid tumors. So, for example, for high-grade serous ovarian cancer, a lot of the medications that are tested in high-grade serous will have applicability to the other histologies, like the antibody-drug conjugates. Most of the times, the antibody-drug conjugate trials focus on high-grade serous or high-grade cancers. But they're applicable to other tumors, like the mirvetuximab, trastuzumab deruxtecan, different immunotherapy, so bispecific agents, CAR T, CAR NK cells, all very, very early in terms of clinical trial testing, but certainly of interest. Then there are treatments that are more molecularly based or genetically based. So I'll say cyclin E amplification. We find this kind of information on something called next generation sequencing of the tumor. So there are ways of, I'd say, kind of interrogating the cancer to look for, obviously, the histology of the cancer, cell surface markers. And right now, the cell surface markers would include HER2 and then folate receptor alpha that we're using in clinical practice. And then thirdly, looking at the types of sequencing and what genetic events are occurring within the cancer. So, for example, BRCA mutations, BRCA1 or BRCA2 mutations, and applicability to drugs like platinum and to PARP inhibitors. Cyclin E1 or cyclin E amplification. So it's not necessarily a mutation within this gene, but the gene is copied many times. And there are different drugs that are being targeted to that, such as drugs called WEE1 inhibitors and CDK2 inhibitors. Occasionally, we'll find RAS mutations, RAS mutations. And there are now a host, like, 5 years ago, there were no medications targeting RAS mutations. Now there are, a multitude of different RAS inhibitors that are in clinical trials. RAS mutations are occasionally found in high-grade serous cancers, but more often in endometrioid tumors, as well as low-grade serous cancers. I will also say that within low-grade serous cancers specifically, besides the RAS mutation, there's a combination of two medications called avutometinib and defactinib that have been presented, the results have been presented over the past year, specifically in low-grade serous cancers. where this combination, so the avutometinib is a basically it's a clamp that hits different proteins within the RAS pathway. Um, and then defactinib is a drug is a FAK inhibitor, FAK. And the combination of these two drugs works really particularly well in low-grade serous cancers that have RAS mutations. So I think there's going to be a ruling by the FDA in just a few months, I think it's June, where we might be able to use these two medications off clinical trials through an accelerated approval. So more to come on that. So really, there's a lot going on. Lots of new antibody drug conjugates that are being tested in ovarian cancer besides Elahere, mirvetuximab, besides trastuzumab, deruxtecan, or Enhertu, looking at other cell surface targets, and looking at other types of payloads that are being attached to the antibody. And I'm happy to talk about them if anyone wants to.
Yeah, I do have a follow-up question on the ADCs, but I'll come back because we have so many questions here. So I see the next question is from Dion. I know, Dion, you're here. So if you would like to ask Dr. Matulonis directly, please go ahead. Okay, while she's getting on, in the interest of time,
Oh,
was
okay.
there you go. Okay, no, not yet. So
Sorry, go ahead. Sorry, I had trouble getting a hold of it, and I actually don't even have the question in front of me, so I'm not even
okay.
sure. But I'm in the middle of typing up another one.
So she's joining from Canada, Dr. Matlonis, and
Great.
so her question is that she was diagnosed with Dion, stop me any moment if I go off track, okay? So
Yes.
she was diagnosed with clear cell stage 2 in January 2023 and
Mhm.
had 1 year of NED, recurred in May 2024. Both her cancer treatments in 23 and 24 were platinum based. Since then, she has started another treatment in December last year. But again, to the question that was asked before, kind of similar, that every treatment she has had significant reactions to the treatment to the point where they had to cancel.
Hmm.
So they tell me I'm platinum resistant now.
Mhm.
So
Mhm.
the current treatment is Avastin and Calyx.
Felix.
Mhm.
Yeah. Yeah.
Okay, and that was stopped on February 19 due to the side effects with her hand and feet.
Mhm.
So she's asking, please tell me there are still lots of options ahead of me, and can it be told why no matter what I'm having done, I always have a reaction to it. I just want
Yeah.
to find a treatment that that gives me many more years free of significant side effects.
Yeah.
Yeah.
Sorry, doctor. That's the key thing. Like the other lady, I guess, is that like you probably can't tell from here, but right
Yep.
here.
No, I can see it. Absolutely, I can see it.
Yeah. Okay. So that's what's come out on my hand,
Yeah.
and it's already started to peel. The thumbs are. They expect my feet will. They're blood red, but no matter what, I was on cisplatin, which they changed me to. That was horrendous, and it seems like no matter what it is,
Yeah.
whatever, there's always something there that gives me a side effect that is to the point where it makes them have to stop the treatment
Mm.
and either try to move on to something else, give
Mm.
it a break, which is what they're doing with the calyx now, giving it a break and just doing a Avastin. Uh, but maybe it's just me because if I'm going to get something or get something weird, it's going to happen to me. And I know side effects come with this, and I expect that maybe I'd have a side effect, and I don't mind that, but I want to be able to live or have a quality of life and still function with that side effect and not have it be so detrimental that they say it's too serious to give me the treatment.
Yeah, no, I'm so sorry. That's really really hard and challenging, certainly for you. And so I would say, you're clearly very sensitive to medications, and really just to think about that. And sometimes people are, right, their blood counts really are quite sensitive and they drop. And in those cases, you sort of you kind of anticipate that that's going to be a problem moving forward. So, maybe start off with, a different schedule where maybe the dose is not as high,
Right.
but is given more frequently.
Yeah.
And that's probably what I would think about for you is either, there are different ways of giving calyx. You can give it, sometimes you can give, because it's the dose, right? It's the dose that's giving you
Yes.
that skin side effect. So one possibility would be to lower the dose, like in half, like
Right.
40 milligrams per meter squared, give you 20 milligrams per meter squared, um, and give it to you less frequent, or more, I should say, strike that, more frequently. So sometimes I'll give somebody weekly pegylated liposomal doxorubicin. I'll give it to them every other week, where you sort of add up the 28-day amount as sort of aiming for 40 milligrams per meter squared, but certainly you can go down from that and go down to 30. So, again, your oncologist can get a little creative in terms of giving it to you, especially if the drug is working. It's really hard when somebody comes in and they're having bad side effects, but the medication's working.
Yeah.
Right.
In
So
that case,
that's what we're trying to get to see. We have not
yeah,
done. I just had 7 liters of fluid removed from my stomach, but they say that there hasn't been enough time yet to see if
right.
if the drug is working, right?
How,
And
how,
that's what we're trying to get to
how
find out.
many, yeah, how many cycles of Calyx have you received?
Just 2.
Just two. Yeah. Yeah. I mean, yeah, two or three is pretty reasonable. I think obviously if they want to go and do a third one, and but continue the investment. But when you're feeling better, to continue the third,
Right.
but you have
Yeah.
to be feeling better, right? So for clear cell, immunotherapy. So immunotherapy has not had a major role
No.
in ovarian cancer, but in clear cell, it has. And we have run a trial at Dana-Farber that has included a drug called pembrolizumab or Keytruda, combined with another medication called lenvatinib, which is a kind of a really super potent anti-angiogenic drug like Avastin, except it's oral. But there have been other trials, single agent Keytruda, nivolumab plus ipilimumab. So that would be something else to consider
Okay.
for you,
Hmm.
potentially on a clinical trial. Uh,
Okay.
the other clinical trial that we've just started is a medication called an anti-HIF2 alpha. HIF
Okay.
alpha drug, which is another medication that blocks new blood vessel growth. It's been used in kidney cancer, in clear cell kidney cancer. And we've just started the trial, so I can't really comment on it because we haven't had enough folks start on it. And then, also I would think about, checking cell surface markers, checking folate receptor alpha, checking HER2, and then also doing sequencing, next generation sequencing on the cancer, because you just never know what might be found when you do sequencing. That could lead to, unearthing or, making other treatments more viable for your cancer in you.
Sure. Okay. And I believe I heard this is being recorded, right? Because there's no way I was able to write off.
Yes, yes,
Okay.
Dion. We are re-recording for
Okay.
others also. So yes,
Okay.
so
Yeah.
thank you both.
Thank you. Thank you so much.
Dr.
No,
Matulonis
good
from
luck. I'm so sorry you've had Calyx. It can be a very tough drug, and certain people are just more affected. And just stay out of the sun.
Right.
But you're in Canada, so there's probably some sun there.
And
It's
I'm in Newfoundland, so it's no sun here at the moment. But yeah.
yeah.
okay. So going from Canada to Switzerland, Dr. Matulonis,
Yeah.
this is Tam Smith from Switzerland, and she's asking, how do you stop Avastin without a rebound effect? And is there a protocol for it?
Huh, a rebound effect. What do you mean a rebound effect? I'm not sure what you mean by that question.
Um, Tam is here, I think. So, Tam, if you want to follow up.
I've read that when you stop Avastin, it can suddenly you get a regrowth that's a lot stronger.
Yeah, I mean, I think it's potentially theoretical. I must admit, I have not seen that. I mean, I mean, I guess if it's happening to you, it's happening to you, but I I have not I have not personally seen that. I mean, I think it so I don't it's I think if it really is an issue, I'm not sure that you can necessarily prevent it, except quickly anticipate it and then move on to something else. But in my experience, I have not, I use Avastin sometimes in folks with newly diagnosed cancer in appropriate situations. And then in the recurrence setting, typically either combined with weekly Taxol, which is a very potent regimen, or with liposomal doxorubicin or with topotecan. And I must admit, I have not seen a rebound effect.
I've been taking it for a year now with letrozole because I watched one of your previous videos
Yeah.
that said get tested for the estrogen progesterone. So
Hmm.
I did that and it came back 100% estrogen positive.
Mm.
So thank you.
Oh, you're welcome. Hope things are well, which is great.
At the moment, I've been a year stable.
Great,
Thanks to
great.
you.
So I went, so if the Avastin hyper progression has, I don't think it's going to happen. I would say it's probably not going to happen. So I wouldn't worry about it.
Okay, thank you.
All right, so I'm going to go to the chat now just to change up.
Okay.
I do see a question from Chelsea, and she's asking, Chelsea, if you're here, would you like to ask Dr. Matulonis directly, or I can ask for you, whichever you prefer?
Yes, hi there. I was wondering, do you have a preferred growth colony stimulating factor that you use for patients who are on the day 1 and 8 regimen of chemo with gemcitabine and docetaxel, just for like ease of administration, so that it's not delaying their treatment?
Mm, mm. So good question. So usually when someone starts gemcitabine day 1 and day 8, um, I I mean, unless they've really had drop in blood counts, I will not start it right off the bat. So, again, you have to use some judgment about the dosing of the gemcitabine. The typical dose is 1,000 milligrams per meter squared, day 1, day 8, etc. But if someone's really had significant blood count drops, I will start, maybe 750 or 800. And then on that second week, I mean, it does happen when the blood counts are just too low. So then what I'll do is I'll revert to, maybe dose reducing the gemcitabine a little bit more. And then on day 8, it also depends upon the schedule that you're using. But if you're doing day 1, day 8, um, then adding Neulasta. So either on-body Neulasta or a shot of Neulasta that will last for 15 days. You could not receive a day 15 treatment. It would have to be day 8 and then starting on day 21 again. So a lot of times what I'll do, and this happens even with weekly paclitaxel, is I will use Neupogen or the equivalent of Neupogen. There's so many different generics now. I don't have a preference. What the preference ends up being is what insurance pays for, and our drug authorization people tell me what to write depending upon who has what insurance. And I 99% of the time have no idea what insurance somebody has. Um, but to me, they're probably about basically all the same. And I'll just write for that. And then somebody will take, let's see, let's start on day 1 with the gemcitabine. And I'll give them either, day 3, 4 Neupogen or day 2, 3 Neupogen. Usually 2 or 3 days of Neupogen will drive up the white count so that when on day 8 they start, their white count will be okay, or their neutrophil count will be okay.
Awesome. Thank you so much.
Welcome.
Okay, Dr. Matulonis, let's go to Nepal. How is that?
Nice.
Then the next question is Kishore is asking, Dr. Kishore actually, he's asking how to reduce the side effects of cytotoxic drugs. And
Oh,
this is Kishore from Nepal.
I think, all of our medications, I mean, they're all anti-cancer drugs.
Hi.
They're
Hi
strong.
there.
Oh, hey, you on?
Oh,
That's
no.
great.
Yeah, okay.
So they're all strong. They're all going to have side effects. And I think we all have, judgment about the starting, what drug you pick, and then what what doses that we start at. And also depends upon the situation. So like if somebody has, newly diagnosed ovarian cancer, I'm going to be like 100% certain I'm starting off with the medications that have the chance to, you know, put that individual into remission. And I'm thinking about things in a curative sense. So I want to make sure I'm treating that individual absolutely appropriately and giving them the best chances for a prolonged remission, even a potential cure. If someone has received a number of different medications before, and depending upon what their side effects have been, and those side effects are, certainly neuropathy, drop in blood counts, what is their kid, what are
Hi,
their
sorry.
kidney line?
Can I have a side of dressing?
Uh,
And
excuse me,
Someone's
if
really
you're not speaking, please be
um,
on mute because Dr. Matulonis is responding to a question. Thank you. Go ahead. Sorry, Dr.
that sandwich
Matulonis.
sounds good or whatever.
Yeah.
What was I saying? So it really depends on the side effects that individual has. Neuropathy, drop in blood counts, kidney function, um, and also what symptoms they're having from their cancer. So if somebody has, kind of maybe a lingering bowel obstruction or symptoms of where they're not maybe taking oral drugs that well, I certainly will not use an oral medication. So those are the things I bring into my brain to help decide drug doses, and schedule really to try to mitigate the side effects, and then really alerting the individual who's going to receive the drug about, certainly we can't go over. Well, I think I mean, every side effect, everyone has different experiences with side effects, but the important side effects, drop in blood counts, watch for fever, drop in blood counts, watch for bleeding. Am I going to, is the drug going to affect your lungs, shortness of breath, rash, etc.? Because people need to know when to call us, alert us, send a message in. So that also, because we can start to mitigate things if we pick up symptoms early. We don't really use immunotherapy too much in ovarian cancer, but I mean, there is definitely signs and symptoms, even with the antibody conjugates, like diarrhea, really feeling fatigued. I want to know about those side effects as early as possible. Bring somebody in, look at their lab work, check them out, and see what's going on, and see if those symptoms are related to the toxicities of the drug, or is there something else going on?
Thank you, Dr. Matlonis. The next question is from Liz. Liz, if you're here and if you want to ask Dr. Matlonis directly, please go ahead.
Sure. Let's see. I originally had high-grade serous cancer, was treated with IVIP, cisplatin, and Taxol. I went 5 years, had a recurrence that was treated with carboplatin and Doxil, and I did not respond to those because my oncologist said, now I'm platinum resistant. So I went into a clinical trial with a study drug, which was uliledlimab, coupled with atezolizumab. And that managed to keep my cancer stable. Eventually, they dropped the study drug, and I continued on the atezo. I found when I looked at my CT reports that there was one spot that was not responding, and so my oncologist had me do pelvic radiation last fall. That my PET scan in December showed that I am cancer-free right now, continuing on the atezolizumab. What I'm wondering is, if this should happen again, what my options are. Because I'm BRCA negative, I'm HRD negative, I'm folate receptor negative, and I'm HRD negative.
Okay. Well, that's great that your cancer has responded so well. That's really fantastic. And
Thanks, yes.
atezolizumab is a PD-L1 inhibitor. So that's great that it's keeping things in remission so well. And I think it's very reasonable if one spot kind of emerges, that, as long as the radiation oncologist can really target that spot, that you can kind of root out that kind of rogue spot. So I think that's all very reasonable to do. Yeah, I mean, I think, you definitely have lots of possibilities. I mean, I would also check the cancer for HER2, HER2. And folate receptor alpha is not a negative positive test result. It's a spectrum from 0 up to 100%. So, for Elahere and mirvetuximab, you need, at least for single agents, 75% or higher. But there are plenty of other anti-folate receptor alpha antibody-drug conjugates that are targeting lower levels of folate receptor alpha. So there's one that we've done in testing and is going to come out in a phase 3 trial very shortly. It's a drug called renatibart sesutican. So it's an anti-folate receptor alpha antibody drug conjugate with a different payload than mirvetuximab. So the payload is a topoisomerase 1 inhibitor. Definitely had activity. It's been reported at a meeting in the fall of 2024. So I think just, gathering as much information about the cancer and then sequencing, honestly, looking at the sequencing of the tumor sometimes will help me pick out other medications to move forward to. It sounds like you had the IP cis and IV and IP paclitaxel 5 years ago, had carbodoxil, and in the clinical trial. You haven't had paclitaxel since, many years ago. So weekly paclitaxel is a very active drug. Um, and so that's another possibility as well, as long as you can tolerate paclitaxel.
Thank you.
Yeah, you're welcome.
Thank you, Dr. Matulonis. The next question is from Danny, and I see Danny is here as well. If you would like to ask Dr. Matulonis directly, Danny.
Hi, Dr. Matulonis. How are you?
Good. How are you?
I'm just curious. I have been through it's 3 years of something. I've had Taxol and carboplatin. I've had Doxil. I've had with carboplatin. I've been on a PARP inhibitor. I've been on Elahere and my lungs were impacted. I am just coming off of or from an adjustment of weekly Taxol, which I did for almost 5 months, which kicked my butt. And I was just exhausted. And now I'm on every other week, which seems to be better.
Yep.
Exactly. With the Taxol and the Avastin. My question is, I keep looking for what's next. NHER2 is something that my doctor has considered, but I am, like a dog with a bone, on HIPEC. And I know that they prefer to do HIPEC when you've had surgery, but do they ever do it later on? Or like I've offered and said, well, you can have my gallbladder and you can go in there and do that.
Yeah.
That's cool.
Yeah. So there has been a trial recently published in Lancet Oncology about using HIPEC in the recurrent setting. But usually, you remember, HIPEC is heated intraperitoneal cisplatin. So that's traditionally HIPEC.
Right.
So if the cancer is resistant to cisplatin, I don't think you're going to find a surgeon to do basically, you got to go in, right? You can't do it without surgery.
Right.
So that doesn't make sense because the drug is not going to be sensitive to the cancer. So I would think about other things. I mean, I think if somebody has platinum sensitive recurrence, I mean, there could be a role for surgery, depending upon the areas of cancer. the resectability of that cancer. And then, some surgeons will definitely use HIPEC, but HIPEC does add side effects, but it could be contemplated. I think that the idea of, targeting the antibody-drug conjugate to HER2, using Enhertu, makes sense. And then, there are a lot of phase one trials out there now, that are testing different antibody-drug conjugates, that now allow a previous antibody-drug conjugate to already have been used. And that's even true of same target. So we've had the Renatibart trial open, for a while now, and that allowed uh, women to enter if they had received prior Elahere. So again, same target, same folate receptor alpha target, but a different payload, within the antibody drug conjugate. So I wouldn't dismiss phase one trials, as being kind of more long shots, because a lot of them, are very appropriate, especially if your cancer has been really continued to be sensitive to different drugs.
I mean, they've all worked to some degree or another, and then when we go on to something else, it doesn't work. Then it all comes back.
Yeah.
So,
And then for you, I would also think about the sequencing, understanding next generation sequencing. Um, that gives me clues about, what the cancer, sometimes it doesn't unearth anything, but
right.
sometimes it does. You just never know until you do the test.
Great. Thank you.
Oh, you're welcome.
Thank you, Dr. Matulonis. I know there was a question that Alice had submitted, but I see her here. Alice, would you like to ask Dr. Matulonis directly?
Sure. Thank you so much. I thank you for being here too. It's really a great, wonderful treat.
You're very welcome.
I am just facing a first recurrence after 3.5, 4 years now. First line high grade, no BRCA negative, HRD negative, carboplatin, Taxol, and also para-aorta surgery because that was the initial metastases. Then a PARP inhibitor, Zejula, and a first recurrence in large para-aorta lymph node about a year ago. That was wait and see, and then expanded to 6 nodes, biopsied, confirmed cancer, and SBRT radiation for that in November. And then just a month and a half ago, the PET showing great, those reduced. However, now paratracheal infiltration, it lit up on the PET. And oh, forgive me, I don't know all the specifics of but essentially in the chest area, and a lot of more nodules and nodes enlarged, but not lit up in the lungs. And I have pretty rough labored breathing for the last 6 months or more, but I also should say that I have very minimal lung capacity due to a 100-degree scoliosis in my chest for a very long time. So anyway, that's kind of a sidebar, but important one. The question really is, and forgive me for the long entry here, but how I'm now presented with the Rena-Taber trial.
Yeah.
However, I was so great at being platinum sensitive, not resistant, and also the 8 millimeter is about the largest of the enlarged nodes now. I don't seem to maybe potentially qualify because they're not big enough. They're there. And the question really is, and then I'm presented with carboplatin and Doxil as bad. But how to decide wait and see is potentially a thought. I like that thought, but I don't know. It's a scary thought.
Yeah. I guess, I think an 8 millimeter node is pretty small. So I don't.
Oh.
Yeah, that's 8 millimeters is, technically, normal size. So I guess if it lit up on a PET scan, one might be a little bit more suspicious about it. But
Oh,
yeah,
it did.
8
Oh,
mil
it
lymph
did.
node, you're not gonna qualify for clinical trial. At least has to be at least 10 millimeters or a centimeter. Um, I guess the nodules, you really have to make sure that, and that's the other judgment part, is that what comes up really represents cancer. Like, is that really recurrent ovarian cancer, or is it something else? And I think that's why sometimes I don't necessarily jump into something with somebody, because I need to be 100% sure, not 95, not 99, but 100% sure that we're dealing with recurrent cancer, as opposed to, oh, I had a cold and there's a lymph node in my neck, or I just, I'm recovering from COVID and there's some lung changes. I mean, you just really want to make sure. So I'm not doubting the diagnosis necessarily, but yeah, that the small findings, sometimes if somebody has small findings and they really want to, and they feel fine, and we just happen to pick this up, sometimes a hormonal therapy, like somebody mentioned, letrozole before, that sometimes, certainly for a low grade tumor, that would be very appropriate anti-cancer therapy. But even sometimes in the setting of a higher grade cancer as well. So unless you're 100% sure, you might want to wait this one out and just follow you very carefully.
Oh, okay. Interesting.
Yeah, because to get on a clinical trial, there really has to be, specific measurements. They don't have to be very big tumors, but big enough to follow. And that for a lymph node, it usually has to be, over a centimeter.
I see. And going on carboplatin and Doxil as the alternate option also needs to be really
Yeah.
100% thought through. And yeah, okay. The biopsy did confirm cancer, so
Mhm.
there is that. But
Yeah. And I think the other important part is to make sure that, you're looking at nodules versus lymph nodes. Um, Nodules have to be at least a centimeter. Lymph nodes have to be bigger to get on a clinical trial.
I
So, yeah, just all has to be kept in mind.
okay, very good. Thank you very much.
Thank you, Dr. Matulonis. On the lymph nodes, there were questions from several people on this particular one about recurrence that happens specifically in lymph nodes. So what and these both, I think, the three questions on the same thing came, and it was all for clear cell. Or generally, what is your thought or recommendation for recurrences that happen in lymph nodes? What is
Yeah.
the path
I mean,
forward?
I think that um, lymph node only recurrences tend to be, more slow growing, more treatable. I think if it's I would take into account, all the clinical factors, but also where the lymph nodes are located. And if it's just one set or if it's multiple. If it's a single lymph node, like we talked about earlier with somebody presenting with a single lymph node in the neck, that might be treatable with radiation therapy. That way you won't need any kind of chemotherapy, and sometimes even surgery is possible. That's another possibility as well. Maybe with radiation therapy given after surgery. I tend to, on single lymph nodes, try to either take those lymph nodes out surgically or use radiation therapy or both, and not try necessarily to use systemic treatment just to kind of tackle one lymph node. If there are multiple lymph nodes, then I would think about all the different treatment options that you would use for anything else. Think about the sequencing. What are the genetic events in the cancer? What's someone's past history with chemotherapy? And then now cell surface markers like folate receptor alpha or HER2.
Thank you. I see the next question coming in from Maritza, and I know that she's here as well. Maritza, would you like to ask Dr. Matulonis directly?
I'm not feeling so well. If you could just read my question, I'd appreciate that.
Of course. So her question is that she's on Avastin but her CA-125 is at 277 and fluctuating between 235 and 305. CT scans and MRI are all clear. So what else could be happening here?
Well, I think, I mean, if all the scans are clear, um, I mean, I would have to sort of look at those scans. I mean, it's a little unusual to have clear scans, but still have an elevated CA-125. So the possibilities are that, maybe the scans are not picking all the cancer up. So there's really something there. In that case, if the CAT scans are clear and the CM5 is still elevated in the 200s, almost 300, I would probably, think about doing PET scans because the PET scans might unearth something that you're just not able to see on CT scan. Um, and if everything is really clear, it depends upon the scenario that you're receiving the Avastin, but you might want to back off the Avastin, especially if you're not feeling well, if there's no evidence of cancer present. I don't know the exact clinical scenario that you're in. Um, the other thought is that sometimes Avastin by itself can sometimes cause elevation of the CA-125. So I get questions a lot that, somebody's on chemotherapy, their scans are getting better, but the CA-125 is going up. And that can happen with Avastin. It just has that property of just, kind of spuriously increasing the CA-125 when that doesn't necessarily match with what's going on in the CAT scan. So you just have to kind of say, okay, look, we're going to follow the CM5, yeah, but I'm not going to react to something that's coming up, especially if someone's feeling well and their CAT scans look okay.
Thank you, Dr. Matulonis. It's such great guidance. A few more questions here. Tanya I'm leaving the last question that came in from Slovenia so that we can do the world trip and finish there. But before we go there, so there's a question from Tanya. She's asking, she's low-grade serous, and so how do I continue to manage the pain and fatigue of taking letrozole for 9 years and have been told I'll be on it for life or if it stops working?
Well, this is a tough drug. It can be tough. I think that if you really need to be on it, I mean, you've been on it for 9 years, so that's great that the cancer, it depends upon if the cancer is still present and not and still present and you can see it, or if you were diagnosed and then placed on it and you're now 9 years later. I mean, one option would be to say, can I take a break? If the former is true, that you still have cancer present, and the letrozole is controlling things, one possibility would be to switch to another aromatase inhibitor. So there are other aromatase inhibitors besides letrozole. There's Arimidex, and then I'm blanking on the third one. I don't can't remember the name of it. Anyway, there's a third one. But you could switch to a different aromatase inhibitor, which is possible. I mean, I tend to use either letrozole or Arimidex. But I would want to know a little bit more about your case, and because 9 years is a long time, which is great, and congratulations. But if there's really no evidence of cancer, you may be able to come off of it. But again, I don't want to say that definitively without really knowing what's going on.
Sure, that makes sense.
But there's nothing to take to try to mitigate those, the fatigue and the joint aches. It's just that is one of the, really awful side effects that sometimes happens to people with aromatase inhibitors.
Thank you, Dr. Matulonis. The next question is from Sharon, and I don't know if you're here.
I am.
Okay, please go ahead.
Hi, Dr. Matulonis. It's
Hi.
been a while. So over the last couple of years, I had a bowel obstruction event. I was in the hospital for like 2 weeks last January. and it resolved. I went on cisplatin and Cytoxan, when I was in the hospital, and then I went off that after 6 cycles on letrozole. I recurred. I'm back on the Cytoxan, cisplatin, and it's working. But I'm celebrating my 9th year anniversary this March, and just curious, what and I'm not a candidate for targeted drugs. I don't have the folate receptor, the HER2. I've done the sequencing.
Yeah.
And so just curious, what trials there might be for me, or your thoughts going forward.
So I'm just, before I answer your question, the other aromatase inhibitors, aromasin, I rarely use that drug, but that's the third type of aromatase inhibitor. For your question, I think that again, I would want to know specifics about the folate receptor alpha. Is it really 0, or is it negative? Because even someone's got 30%. Folate receptor alpha may qualify for certain clinical trials.
I think it was like 10%.
10%, it's not 0. So that's a possibility. And then HER2, comes in 4 different types. It's either 0, 1, 2, or 3 plus. So if it's 3 plus, the drug trastuzumab deruxtecan can be used on a broad accelerated approval from the FDA, tumor agnostic. 2 plus is on the NCCN guidelines that we can use. 1 plus, there are clinical trials of different medications that are targeting 1 plus HER2 with different antibody-drug conjugates. And then there are different antibody-drug conjugates that are marker agnostic.
Okay.
So like TROP2, for example, a lot of the antibody-drug conjugates are not testing. CDH6, another, and there are like a lot of these trials ongoing right now. And then B7H4, those antibody-drug conjugate trials are also ongoing. And there are different ones that don't really, they're getting measured. The cell surface markers are being measured, but you can enroll on the trial regardless of those measurements. They're done kind of after the fact. And yeah, I think so. They're out there. They're in phase 1 clinical testing right now. And I would want to see your sequencing report just to better understand that there's really nothing there that is potentially targetable. But there definitely are other antibody-drug conjugates that are being tested that do not have any specific markers that are and it's not that the drug is not targeting something. It is targeting something, but the expression or presence of that target is really ubiquitous in ovarian cancer.
Okay, great. Thank you.
Thank you, Dr. Matulonis. I'm going to ask you, we are just 2 minutes, 3 minutes away, so I'm going to ask you the question that came from Slovenia. So
Okay.
Mia is asking that she's 59 years old and she's generally in good shape. The first diagnosis was in 2022, high-grade serous ovarian cancer, then surgery, 6 cycles of chemo, and then a little bit of neuropathy. A recurrence happened in 2024, January of 2024, and then she went on to receive 3 cycles of carboplatin and calyx. Then she was on maintenance therapy with Avastin. Then second recurrence happened to the liver and the peritoneum, and then lymph nodes. And so surgery was discouraged because the risk was of the faster recurrence and spread to the other organs. So then she goes on to say that studies have shown that in cases of ovarian cancer recurrence, achieving an R0 resection at the time of the second recurrence may be more important for a better prognosis than an R0 at the first. So I do understand that each patient is assessed on an individual basis, but I would like to ask, generally speaking, which is more important, a third major operation R0 at the time of the second recurrence, or is it better to continue with chemo alone without surgery? My oncologist says that due to the risk of rapid progression of the cancer throughout the body, other procedures on the liver are also not recommended.
Yeah. I mean, I think that, surgery really has to be assessed by a gynecologic oncology surgeon who really has an understanding of this cancer. Because what you don't want to do is go to surgery by someone who thinks they can do the surgery and then ultimately is just not possible. Because especially if you're going to start to do liver resections or hepatic resections, that is pretty unusual in ovarian cancer, just because and again, I think if somebody has a solitary isolated liver metastasis, sometimes we'll do something called radiofrequency ablation or cryoablation, or radiation therapy. We didn't really talk about RFA, but that's another possibility. But I think you have to trust the surgeon, as long as that surgeon's a gynecologic oncology surgeon, if that person wants to do surgery, because they're a surgeon. So if they're telling you, I don't want to do surgery, I don't think it's in your best interest, I think that's a very strong statement, and is probably not going to help you, because sometimes you go to surgery and the surgeon can't do the surgery, but you're left with a large wound. The wound dehisces, the wound gets infected, you're in the hospital. I mean, all these complications can occur, and it sets you back. And all that time, the cancer could be growing. And so you end up delaying treatment because of the fact that you had surgery and any potential complications that have occurred. So I would, just from what you said, it does make sense that the surgeon said no to surgery. I hope I'm answering the question.
You did. Thank you so much, Dr. Matulonis. I'm going to bring everyone back on to the screen. On behalf of everyone, I would like to thank you so very much for spending an hour with us. We know that your time is super, super, precious, but you take the time to spend with us and answer our questions. We truly are grateful, and we appreciate you for all the great work that you do and continue to do for our teal community. So thank you for joining us today. And Overcomers, hope this episode was beneficial for all of you. We got many, many questions asked. And if there are any follow-up questions that you would like to ask Dr. Matulonis, please go ahead and send them to info@overcome.org. And we will try to route it to her. If she's not too busy, she will help respond to those questions. So with that, thank you again for joining us, Dr. Matulonis, and we'll be back with the next episode very soon. Thank you all.
Take care, everybody. Nice to see everyone. Take care.
Thank you.
Bye-bye.
Thank